Antimicrobial Stewardship. Introduction. Treatment with antimicrobial agents seems so effective and safe that they are sometimes prescribed for dubious indication and for longer than necessary, with little concern for adverse effects and the development of resistance. Antimicrobial stewardship (AMS) is thus a coordinated systematic approach to improve the appropriate use of antimicrobials by promoting the selection of the optimal antimicrobial drug regimen, right choice of antimicrobial, right route of administration, right dose, right time, right duration, and minimize harm to the patient and future patients. CDC estimates that more than 2.8 million antibiotic-resistant infections occur in the United States each year, and more than 35,000 people die as a result. About 30% of all antibiotics prescribed in U.S. Objectives. 1. To improve patient outcomes, e.g. reduce morbidity and mortality from infection. 2. To optimizing antimicrobial therapy, by promoting judicious use of antimicrobials, optimizing antimicrobial selection, dosing, route and duration of therapy in order to maximize clinical cure or prevent infections. 3. To limit unintended consequences such as the emergence of antimicrobial resistance and adverse drug events. 4. To reduce healthcare cost without adversely impacting quality of care. Core elements of hospital antibiotic stewardship programs. 1. Hospital leadership commitment. Dedicate necessary human, financial, and information technology resources. 2. Accountability. Appoint a leader or co-leaders, such as a physician and pharmacist, responsible for program management and outcomes. 3. Pharmacy expertise. Appoint a pharmacist, ideally as the co-leader of the stewardship program, to help lead implementation efforts to improve antibiotic use. 4. Action. Implement interventions, such as prospective audit and feedback or pre-authorization, to improve antibiotic use. 5. Tracking. Monitor antibiotic prescribing, impact of interventions, and other important outcomes, like difficult infections and resistance patterns. 6. Reporting. Regularly report information on antibiotic use and resistance to prescribers, pharmacists, nurses, and hospital leadership. 7. Education. Educate prescribers, pharmacists, nurses, and patients about adverse reactions from antibiotics, antibiotic resistance, and optimal prescribing. Policy. 1. Formulation of AMS team in the hospital. The core members of AMS team should be multidisciplinary and appointed by hospital director. 2. Antimicrobial selection and dose optimization of the antimicrobial agents. Antimicrobial selection and dose optimization should be based on clinical indication of individual patient and current clinical guidelines. 3. Establishment of antimicrobial order form for restricted antimicrobials. Antimicrobial order form should be completely filled by prescribers before sending it to pharmacy department, especially for intravenous IV antimicrobial with broad-spectrum activity. 4. Establishment of formulary restriction and pre-authorization approval system. 5. Streamlining the antibiotic usage. Appropriate selection of antimicrobial when there is a need to prescribe 2 or more intravenous antimicrobial simultaneously to prevent overlapping in the spectrum of antimicrobial coverage. Antimicrobial prescribing must be reviewed no later than the 72 hours after it has been initiated and de-escalated to narrow-spectrum agents promptly when appropriate or based on microbiology results. Relevant data such as stop or review date, indication, etc. should be documented in the medical notes or on the drug chart. 6. Initiation of intravenous IV to oral PO switch program. Intravenous antimicrobial therapy must be reviewed and switched to oral alternatives when clinically appropriate and available. 7. Formalize regular antimicrobial rounds by AMS team. Identify and suggest streamlining of antimicrobial, e.g. choice of antimicrobial, de-escalation, dose optimization, IV to oral switch during the rounds. Impact on antibiotic utilization data and acceptance rate should be documented. 8. Surveillance and feedback mechanism on specific antimicrobial consumption. Surveillance and feedback on antibiotic utilization should be conducted regularly or at least twice a year. Report of this surveillance and feedback must be submitted to state and national level. Necessary action should be taken based on surveillance finding and local resistance pattern.